Good morning. Tina?
Morning.
Hey.
Morning,
Megan,
Commissioner.
how are you?
Good.
Morning.
So do we have, is Tina there?
For some reason she put us on hold. Let me call her.
Okay. I think I'm going to go ahead and admit everybody. Good morning. We're just waiting for a few more attendees.
Hear you.
Commissioner, I have Tina on the line. Are all the doctors available?
Yes,
Oh.
they are.
Okay.
They're here, gloves on.
I see. Okay. All right.
Okay.
I think we're
All
good.
right.
Okay, bye.
Yeah.
All right, Commissioner. We are all set.
I don't see any of the doctors on here.
Let's see. Attendees. I think we have to hold on 1 second. I think we have to bring them in.
We might be on the wrong.
Well, because there are 2 links here.
Thanks everybody for your patience. We had 2 meeting events created, so we are just working on getting this ironed out. Stand by.
Appreciate everyone's patience as we sort out a minor technical difficulty. We should have all the members of the board or the members that are attending on shortly, and we'll get started. Thanks.
Waiting a little bit.
Tina, are you trying to invite the physicians back into this one?
It looks like some of them are still trying to reopen on the other one. And I'm
Okay.
sending the messages to open this one. There's no one in the breakout room here. Okay. See you.
Oh, you hear me now?
Yes, you're in the correct one now. Perfect. Thank you. There we go.
I think we just need Dr. Perlson.
Perfect.
Did you send it to Dr. Perlson, Tina?
Yes.
Okay.
Here he is, I think. No? Oh.
Is that everybody, Tina?
I think we're still waiting for Dr. Perlson. I don't see him yet.
No, he's here.
Oh, perfect. Then we're good.
But and
Okay, great.
Dr. Primus is here as well. Okay, good.
Yes, we're all here.
Are we waiting on I thought that we were expecting 4 doctors to attend.
We are. He is. Dr. Primus is in the meeting. It's just we just can't see him on camera.
Oh, well, why don't we just elevate him to a attendee, which I'll do right now.
I believe he was.
Now he is. So he's. Do we have to turn his camera on, or Tina, or?
Let's see. Looks like he
He's
went back out. Oh wait, no recent. Let's see.
he's in the presenter group, but his camera wasn't on before, and even in the
Right.
other meeting, it was blacked out. So I don't know if it's
Oh,
seeing
okay.
that blackout or not. Dr. Primus, are you able to respond at this point? Now he left.
He left out.
Again, to all those who are attending as guests and watching, we are trying to correct this in short order, and we'll get the meeting underway. We do need 4 members for a quorum, so that's why I'd like to have the additional member rejoin before we get underway.
So I think they're all there now. I see Dr. Stalner, Dr. Perlson.
Dr. Primus, can you hear us and communicate back at all?
Okay, can you hear me?
Yes.
Yeah,
Okay,
great.
my mic was turned off. I apologize for that. I don't know why.
Okay.
I am here.
Thank you,
Perfect.
Doctor. Thank you, everyone. So at 9:17, I will call this meeting to order. And I trust that everyone received the minutes from our last meeting, which was in October. I'm wondering if you had a chance to review them, and if so, would someone like to make a motion regarding their approval?
So moved.
Is there a second?
Second.
Okay, thank you very much. The motion has been moved and seconded. All those in favor, say aye.
Aye.
Raise your hand. Any opposed? Any abstentions? All right, well, then the minutes pass. Moving along to agenda item number 3, we have a program update. I can just weigh in very briefly here. in terms of the program has about 42,300 patients, 891 patients and 1,745 certifying physicians. Just wanted to remind you that we no longer have application fees for patients and caregivers as of July of last year. In terms of production on the marijuana, the drug side, we currently have 4 expanded producers, 1 micro cultivator, 1 DIA cultivator up and running, and many other licenses in the process of getting their doors open. We will have more cultivators up and running within the next upcoming month, and Affinity Grow has started their operations. And I, at this point, would like to turn it over to Rod Marriott, the drug control director, who you are all very familiar with, to talk a little bit about the proposed federal reclassification and its potential impact on the program. And I think that he may have some clarification on the numbers of patients that I just read. I may have misread some of those.
Yeah, apologize for that. There, it appears we were working off an older document that, but ultimately we're at the end of April, we're at 40,000 patients, 1,808 certifiers. We have had 2 new micro cultivators open or at least get approved for final licensure in the last few months. Since the last meeting, definitely. And one of them has applied for an expansion. And so that should really help add to the diversity of supply for the market. And we're looking forward to that. But there is a time lag between kind of getting your plants kind of quote unquote in the ground and the product hitting the market. And one of our DI cultivators has been contributing product to the market of late as well, which is really encouraging for the market as a whole. As for Schedule 3, there's been a lot of press attention around cannabis and its potential rescheduling. I think the biggest thing for people to understand that this is a pretty long process. Rescheduling is a long process. So there'll be a period of time for public comment. So for those of you that are interested, you can comment in the Federal Register's publication through their website. And then the Drug Enforcement Administration and other kind of federal agencies will need to look at the comments and respond. And there can also be hearings that are held about the rescheduling. At this point, our initial assessment is that the immediate impact on our program is very minimal, if any, at the moment. It may have some positive benefits for businesses as far as tax implications and things like that. But at this point, we don't expect any significant disruption. As a general reminder, Connecticut moved marijuana to Schedule 2 at the inception of the medical marijuana program. And so the Schedule 2 to 3 change doesn't alter too much for our program as a whole. Does anyone have any questions about that from the board that I can answer at this point? Go ahead, Dr. Salmer.
Rod, quick question. I know that because of the schedule, federal scheduling currently, I know that some of the producers and dispensaries have a problem with their banking and financial arrangements. Will that ease up during a consideration, or will those things have to actually wait until the rescheduling occurs?
There's potential 2 things that could impact kind of the bankability of the cannabis program. One is the rescheduling, but it would have to actually move to Schedule 3 to alter that restriction. And then there have been a number of bills submitted at the federal level to open up banking and the rules around 280E. And I believe there is a bill that's still pending out there for that, but the movement of that is subject to the will of the legislature.
Thank you.
Rod, at any place, is there an official listing of the expanded and micro cultivators? Is that on the website somewhere?
Yeah, we have on our e-license website, which is kind of where all of our licensing is, you can see that. I believe we also may have some lists elsewhere. But I can send you something specifically if you'd like after to get a listing of those.
Yeah, that's
yeah,
just curiosity, but yeah,
Sure.
that would be helpful.
Yeah, so the all of our four kind of what we kind of affectionately call our legacy producers have expanded. So those are kind of the usual people, and then the three new micro cultivators, and the one kind of newest type of cultivation is the disproportionately impacted area cultivator, which is part of the kind of all the adult use law. That's a bit of a newer area.
Thank you.
I'll send you a list after.
Rod, Dr. Price, I have two questions. Could you explain to us as a group what the micro cultivators do, what their purpose is? And the other question I have is regarding the rescheduling. With reclassification to a Schedule 3, would that implicate the fact that any physician could then prescribe cannabis, or would they still have to go through our program?
So for your first question with the micro cultivators, they are basically just a small cultivator. It was just a separation on the amount of space that they can open with. So there's a separate floor and a ceiling. A micro cultivator has a floor of 2,000 square feet of grow space and an initial cap of 10,000 square feet of grow space. But they can expand, and then eventually can expand up to a full cultivator. The law prescribes that 15,000 square feet is the minimum for a full cultivator. And so that's the only real difference. There were some other nuanced differences where they can make certain deliveries that to non-medical patients. But those ultimately or ostensibly, they're the same. They're just one is a smaller version of another. Other states have taken a tiered approach to the cultivation licenses. We just really built out 2 tiers with a micro and a full cultivator. As far as your question with Schedule 3, I don't think it alters our program much, because ultimately we rescheduled it and it kind of creates this kind of restricted environment. It prescribes when a person can certify. And so right now we have a list of conditions, which some were created by the legislature directly and others were created with help from this board of physicians. And so it appears that would remain the same. It's cannabis, the rescheduling of cannabis is in its entire plant, right? And so right now there's no other pharmaceutical that comes as a plant or formerly a living thing so directly. So it doesn't appear to change much. Most drug schedule changes are chemical changes, not kind of whole plant changes. There are other examples of scheduled plants. Some you may know, like the poppy plant, which is the source of some of our opioids, or many of our opioids. And then there's a cactus that creates peyote. And so people are not out there prescribing cactuses or poppy plants on a regular basis. And so I expect it to be somewhat similar.
Just one other quick question. There was once a discussion about some of the cultivators developing products outside of the usual forms, like having infused THC drinks and other kinds of products. Is that still in development in Connecticut?
Yeah, so infused beverages got a lot of attention this past legislative session. The facilities in the different parts of our supply chain will have the ability now to make beverages. There are some beverages that are kind of classified more like hemp that are available in the market today, and there's a new cap that is effective July 1st on that of 3 milligrams max per container, and that container has to have a minimum of 12 ounces.
Okay, but this is regulated differently than going through the dispensary.
So the parts of that are, but we've tried to, the law has tried to mirror a lot of what our cannabis program has with the testing and things of that nature. And they're pretty harmonized right now. And we will continue to kind of communicate with the industry about those products. They also will be after July 1st, really age gated, so that they will be only permitted for sale in the licensed cannabis industry, separate from the cannabis products, but also in package stores. So, and you have to be 21 to buy.
Interesting. Okay, thank you for that clarification.
You're welcome.
All right, anything else, doctors?
Mm.
Then we will move along to agenda item number 4, the public hearing on petitions to add debilitating conditions. And the first one, A, is the autism spectrum disorder. And so I would assume that you've all had a chance to read the petition and the materials. And is there any discussion on this? Would you like to hear from the petitioner?
Absolutely.
Yeah,
Okay.
always helpful.
Yes. All right. Tina, is the petitioner in the
Yes, they are there.
can you
Sorry.
call on them and allow them access, please?
Absolutely. So Cheyenne, are you there? Have you been let me allow her open her mic.
Hello, how are you guys?
Perfect.
Hi, good morning.
Hi, good
Good
morning.
morning. My name's Cheyenne. I'm actually a nurse practitioner in the state of Connecticut, and I actually participate in the program and help write cards for people. I've learned so much about this plant and how amazing it is. So I spend a lot of time educating patients and providers about how awesome it is. So I actually was diagnosed with MALS last year, which is when I ended up getting my medical card. I was diagnosed with autism spectrum disorder when I was 20 years old, which is pretty common for women like me. Most men are diagnosed around the age of 3. So I was getting my doctorate and working on additional testing types of questionnaires to help just find girls easier and help physicians identify them based on their gender differences. One thing I did find through my research was only how much my symptoms improved when I started a CBD and THC tincture. It was so profound that I started doing the research and found myself writing a petition to help other people who suffer from similar symptoms, such as sensory issues, anxiety, depression, social cognitive issues, and all of these things were, it was almost like taking a magical pill. My whole life, I've been on and off different medications because of insurance. The side effects have been awful. I've been on Adderall because of having like the ADHD symptoms. And I was gratefully able to come off all my medications and just be on a CBD and THC tincture. And I think, especially when I was trying to do some research as well with cannabis programs, it was so difficult with access. So I think having this available with so many of those comorbidities that people with autism spectrum disorder suffer from, such as epilepsy, MALS itself, this will be such a great way to just improve the overall quality of life, because we know now over the past 10 years that people on the spectrum do not make enough endocannabinoids. They actually have less serum endocannabinoids, specifically anandamide, which we know stimulates the CB1 receptor. So if they're not having a release or inhibition of those neurotransmitters or neurochemicals, they are definitely going to be having those symptoms. So I think this is an awesome way just to increase access and improve the quality of life for people who really don't have a lot of options out there.
What
And
have you
that's
found that your dose is on a regular basis?
Yeah, so I pretty much do a CBD and THC like tincture higher in the morning with higher in CBD, less THC, and then a little bit higher in THC at night. And then I was able to not have any more insomnia issues. Nightmares were cured with a little low dose THC at night. So it's been phenomenal. And I hope that other people can get the same access. Specifically, I know with children as well, having more education on this when they really are just having more aggression, this can be life-changing for a lot of parents and a lot of families for sure.
Cheyenne, I have a question. It's Dr. Prowess. Do you know if there are any other states that have this condition listed as a precedent? And in your research, is there a great amount of research in this area that we could look at?
Yeah, so you definitely should take a look. There's a significant amount of research supporting it. They've been looking at it over the past 10 years, and about 17 other states have already approved it. And Connecticut has already been on the front line, so I figured we should get back on the board and be able to support our other people with neurotypical diseases, because they really don't get that much, especially when you're an adult. Really, it's very difficult to get diagnosed. There really aren't a lot of places, Easter Sales and the IOL. And again, a lot of those people are not trained in the nuances between men and female. So, but yeah, there's a great research. I think it was 17 when I did my initial research. I haven't checked recently in the last couple of months, so it could be a couple more.
And just to be clear, this was approved in the pediatric population as well as in adult?
So they were studying it in both children and adults. Yes.
Okay, thank you.
Dr. Perlson, you
Dr.
had a
Perl-
question? Oh, sorry.
Yeah,
Oh, no.
Cheyenne,
Good.
sorry.
ahead, Dr.
Cheyenne,
Perlson.
thanks. That was very helpful. Exactly as you say, because this neurodevelopmental condition is more apparent often in boys than girls and is diagnosed much earlier. I was just wondering about the safety considerations in terms of giving this to pediatric or teen populations pre-18. Any concerns on your part about that, and what are your thoughts on that?
So I was thinking about that too, and that's originally when I was looking at the safety profile, specifically with the other medications that are on the market, right? You're looking at pretty much the two approved one are both risperidol and omeprazole, which again are both going to be causing significant metabolic effects on these children. Now, with obesity being a leading cause of disease with almost half of our population, it's like these side effects. So again, when we look at just even being on a full spectrum CBD, we're seeing people are actually having more healthier BMIs in landmark studies when people are smoking. We'll say they only did it with smoking 3 times a week, but I think it was in over like 50 to 100,000 people. They were looking at a lot, and their BMIs were actually normal. So looking at those different medications that are available and their side effect profile, this one's actually much more safer. But again, that's my analysis just from being a prescriber, working with these medications and seeing that they carry just the same risk as, suicidality. When again, THC, you might have some of those, again, I know people are concerned with the schizophrenia potentially being in that, but that's where we as providers can step up and give more information. I've been a patient within other medical providers, and it's quick in and out. And I understand in Connecticut, we are just certifying people, but knowledge is power. They're going to dispensaries, which are really geared towards selling. We know how a for-profit healthcare system works. So I think, again, educating, maybe coming up with something to help get more knowledge to providers is only going to keep your patients safe, but give them a safer option because it is a plant. You know what I mean? A lot of our medications are built off of plants, Tamiflu coming off of Star of Anise and things like that. So I think we can really bridge the gap with using more natural products, which I know a lot of people we want. Natural sometimes is better, So I have seen, in general, I understand there's risk and benefits with everything. But for me, with the current medications that are out there, I would believe that this one actually would be more of a safer profile, especially with the direction of a provider. But again, with kids, I think it should be a little bit different than just a quick in and out appointment. There should be, hey, why don't you start like this, titrate this, 2 milligrams, come back to me. And that comes with also having, tinctures available, which can be difficult in this scene that we see in dispensaries as well. So I think, paying special attention to have those tincture doses is very important, and having providers equally knowledgeable and having the information available to educate the patients, because one pharmacy per dispensary is not going to cut it, especially when these people are new to this, and even providers are so new to it. They don't understand that this system is so apparent in our body and everything that it kind of works. I do functional medicine, by the way. I should probably have started with that as well.
Oh,
So
that's
again,
great.
looking at the hormones of the body was always very important to me. So seeing that the endocannabinoid system not only controls our subtle energy, right, systems with our chakras that we know, it also controls neurogenesis, neuroplasticity. So you can see how same thing with those Alzheimer's patients. They get to that issue and it's a block because they don't have any more bridges. They don't have the neuroplasticity to learn a different way. So you could see how aggression, social issues can come from bad events that they experience. So I'm very excited. I hope you guys can see the benefits of it for other patients.
Cheyenne, Dr. Privacy again, I have another question regarding dosing and tinctures. Have you found a particular protocol with much like in childhood seizures, that a high CBD to THC ratio has been most effective for this condition?
So I would say it really depends on the person, right? So you have some people with autism who really present more with like those ADHD qualities, hyperactivity. So again, when I see those, a lot of those people during the day are going to benefit from higher CBD concentrations with lower THC. But I've seen most of the time it works better paired together, but the ratios are very important. So I would say, again, I always start with a CBD base and then build up from like 10. It depends. I work mostly with adults now, some children more personally, but again, I try to be careful because it's not approved. So I don't try to do things, you know. But so, using that and just incrementing the THC in lower doses. And I typically start that at night, especially with like naive like cannabis patients, start off with that CBD and then kind of bring that in. But again, it's very much similar to like tapering up on a medication, like the Wegovy. You're doing it together and assessing them, moving up a couple of doses, which can be difficult if we don't have that type of dosing schedules available at the dispensaries. So I think moving forward to have like a synergistic relationship, just as THC and CBD does, we need to be able to have the delineations for being able to order different CBD and THC tinctures.
Thank you.
Just
Dr.
a quick
Salner?
question.
Oh, I think
Go ahead, Andy. Go ahead.
he had his hand up.
Cheyenne, thanks for that eloquent presentation. It's my understanding, and this is a question for the commissioner. It's my understanding that the petition is for use in adults, not for children. Is that
For
correct?
sure. Yes, my petition is. I didn't realize that I would have to do a separate one, but I mean, I could always get it going for you guys.
Thank you.
Cheyenne, just real quick. So how often are you seeing your patients when you start them on a dose and then gradually, progress with their visits?
So I work in a naturopathic office with a bunch of naturopathic doctors. So again, I pretty much see them follow up. Like if they're like not cannabis naive, I have them come in or even send me a message. I give them pretty good instructions on how to taper up. So saying take 2 milligrams up dose. And I've gotten that really from Dustin Sulik, who's operates a clinic, I think I want to say in Maine. So that's not my own information. I used it based off of his and his like slow titrating dosing schedules, which have been very effective, very easy to read and understand. And it gives people just like, a little bit safety because of a lot of the just negative news we've had growing up with it. So I think it helps people feel a little bit safer. So I would say usually start them off if they feel comfortable with that dosing. I'll follow up with them in a couple of weeks, but I always say if you're having issues, come back in. A lot of people have used cannabis, I've found. So with good instructions, they usually catch on pretty quick. But I see that's a huge problem. It's in and out with the providers, 15 minutes. They're just qualifying you. So you're getting to the dispensary with just like
No knowledge.
yeah, you know what I mean? And it's not like it's easy to discern on the internet. It's a very complex system. And again, when you're coming to a doctor, even for chronic pain, and they don't know about it, it can be pretty deflating as a patient for sure.
Yeah. Just a comment, Dr. Privacy again, glad to hear that you discovered Dr. Sulak's protocol. He's a friend and a colleague. So I'm glad to see that you're following some of his work.
Yeah, that's awesome. I look forward. I hope I get the chance to meet him. I really would love to. He's quite the little celebrity for me.
All right, any other questions from the board?
Thank
Well,
you so
I
much.
thank-
I really
Thank
appreciate
you
your
so
time.
much for your time, your petition, and your energy. It was really a great presentation, and I appreciate it. Thank you.
Thank you so much. I
Um,
hope to go
yes.
further in the future for sure.
Good luck.
Good. Thank you, Cheyenne.
Have a good one.
I'd
So
like to make
at
a
this,
motion that we approve the petition for use in adults.
is there a second for that,
I second.
Dr. Carlisi? Okay, all those in favor signify by saying aye.
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 Dr.
Aye.
Okay, and then I do have to poll you to just with regard to conforming with the regulations. So do you believe that is this a medical condition, medical treatment, or disease debilitating? All those say aye.
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 Okay, any nays? I guess no. Is marijuana more likely than not to have the potential to be beneficial to treat or alleviate the debilitation associated with the medical condition in the petition?
Yes.
Yes.
Aye.
Yes.
Agreed.
Dr. Prowess?
Yes.
Okay. And then are there other matters the board considers relevant to the approval of the petition?
So this is just for the
No.
adult, not for the pediatric.
Correct. Yeah,
Okay.
correct.
No.
Yes.
Did you have something to add then, Dr. Parvis, or?
No, I'm in agreement with this is for adults only.
Yep.
Okay. All right, great. So the last question was for patients under 18, but since the petition was not for that group, it's irrelevant. So that condition has been approved, and I think there's some paperwork that'll be circulated that you have to sign, so we could take care of that offline. So the next matter on the agenda is the female orgasmic difficulty, B. Tina, is the petitioner here?
Yes, she is.
Okay, can you admit her and call on her to present the petition?
Absolutely. Dr. Suzanne Mulville. Sure, her mic is.
Hi, good afternoon, or actually good morning. It's
Hi,
actually
good morning,
afternoon.
Dr. Mulville.
Good morning. So yeah, I prepared the petition. My name's Suzanne Mulvihill. I have a PhD.
I'm sorry to interrupt you. I didn't know, sometimes it's more impactful if the camera's available. If you could turn
Can
that
you
on.
see me? I believe it's on.
No, it's not.
Let's see. Turn camera on. Just one second. I can see myself.
You
There
just
you
did
are.
it, so
Now
thank
we
you.
see you.
I mean, it's not
Okay.
necessary, but helpful to just.
Can you see me?
Yes.
Now we can.
Yes.
Okay,
yes,
good.
thank you,
Okay,
Dr.
because I can
Yep.
see me. I can see all of
Thank
you
you.
and I can see me. So it's good to
Right.
see you see
Sorry
me
for
too.
the interruption, but please proceed. Thank you.
So thank you, Tina, also for coordinating with me. We've been talking back and forth since September when I submitted the petition. So far, there have been, well, I'll introduce myself first. I'm Suzanne Mulvihill. I'm the executive director of a nonprofit called the Female Orgasm Research Institute. And I also run a subsidiary of that, which is the Women's Cannabis Project, that is designed to get FOD, female orgasm difficulty / disorder, added as a condition of treatment for medical cannabis in US states and countries worldwide. So Connecticut was part of the first group that was submitted. Illinois had its meeting in March and was the first board that approved it unanimously. Ohio did not approve it, but they did not approve the condition that was just autism spectrum disorder was actually also presented at the same time in last month. So, so far, to tell you why I presented this petition, having suffered with this issue myself for more than 30 years and having seen 4 sex therapists, it was cannabis that actually helped me overcome this problem. So it is a shamed condition. It's a stigmatized. We rarely talk about this topic, but I think it's time because up to 41% of women suffer from it. And that statistic has not changed for more than 50 years. And there are comorbid conditions that are cross-directional, meaning it can cause mental health concerns as well as be the cause of anxiety, depression, PTSD, etc. So I want to also add that orgasm difficulty is the #1 complaint, and it's been that's in research by sexual abuse survivors, women who have been sexually molested either as children or raped or whatever as adults. So I would like to present to you a little bit about my research and about the last 50 years of research. So when I went back to school, I actually sold my company in 2020 to go back to school to get my PhD in clinical sexology, so that this work could be done. And I did my dissertation on could cannabis be a treatment for FOD. So I was actually shocked to discover that there has been research going back to the 1970s showing that cannabis helped women with this problem. And there was anecdotally commented as far back as Dr. Eric Good's book, where he would talk about women. He did the first really cannabis and sex study in 1969, and he published a book called The Marijuana Smokers in 1970. I have a copy of it, actually, it's here. And he talked about women who were able to overcome the problem of FOD by using cannabis. Next, we had a woman named she wasn't a doctor, it was Barbara Lewis, who wrote a book called The Sexual Power of Marijuana after interviewing 200 men and women. And she commented directly, and she had interviewed doctors who talked about it, again, helping women who had difficulty with orgasm. And she devoted an entire chapter to marijuana. And at that time, it was called frigidity, and it possibly being a therapy. In 1979, Dolly conducted a study, and he actually was the first to suggest cannabis as an adjunct in treating sexual issues. So this has been on the table as a topic that we have talked about since that time. If we fast forward, there were a few other researchers, Halakis and Weller did 2 studies, also finding cannabis helping women, and the frequency of use was discussed. In terms of recent studies, Dr. Becky Lynn, who's an OBGYN and is one of the few doctors in the country who actually prescribes or recommends cannabis for the treatment of women's sexual issues, including orgasm difficulty. And it's, I had sent some links to Tina. I don't know if they got to you or not, but you could see her website where she talks about that. And she has been interviewed and on radio shows, being one of the few therapists in the United States that actually, one of the few medical doctors. Dr. Jordan Tischler, who is my research partner and the vice president of my nonprofit. He was also my dissertation advisor for 4 years. So he and I did the study, and he actually recommends cannabis. Actually, how I found him was because he was one of the few people when I was looking for a dissertation advisor. He was one of the few people that popped up when I Googled cannabis and sexual dysfunction. His website came up. So that's how I had met him. Sex therapists have been recommending cannabis to patients who have orgasm difficulty. There's a therapist, Diane Ehrman in San Francisco, who's been recommending it since 2017. And you can find a number of articles and research where she's talked about why she recommends it and how it can help. I presented 4 theories in 2 years ago at a conference of why I believe it works based on research. One of them being the amygdala reduction theory that talks about how cannabis, the THC, has the ability to reduce the activity in the part of the brain that stores trauma. And so when we have women who have sexual abuse histories, particularly in PTSD, why it can actually help. So Casman, this is the last study I'll mention. I'll mention Lynn and Casman, then I'll go to share with mine and keep this like maybe 5 minutes. Is that good? So Dr. Kasman did a study in 2020, and he evaluated 453 women who went to a single dispensary in a number of different, in one state, but in a number of different locations. And he found that for each step up of cannabis use, meaning if women went from, in an observational study, once a week they reported, or twice a week, each step up, the sexual dysfunction went down by 21%. So Dr. Becky Lynn, when I had mentioned her earlier, she did her study that was published in 2019. She found that women who used cannabis more frequently were 2.10 times more likely to report orgasm satisfaction. And if you were to look at, she's been interviewed about why she even did this study, was because women were coming to her as an OBGYN saying, listen, this is helping me with these sexual issues that I'm having. And that's why she conducted her study. So my study, I did a study that dichotomized women with and without orgasm difficulty. It was the first study that did that. And I'd like to share that no study ever excluded women who had orgasm difficulty. It just really talked about it. It was talked about how it helped them. But we can assume that if the statistic hasn't changed in 50 years, then up to 41% of the women in all these past studies had orgasm difficulty. So in my study, we found there were 202 women who reported that they did have orgasm difficulty, 52% of the women during partnered sex. And it's important to note that there are no validated treatments for women who have what's called situational, which means they can't orgasm in some situations, but not others. No conventional treatments for any of the subtypes of FOD. So my study showed that in a within study design, meaning we used the Female Sexual Function Index orgasm subscale questions of frequency, ease, and satisfaction with and without cannabis before sex. And it was statistically significant for all three categories. For women, we divided it by the women with orgasm difficulty, which was 202, and then we evaluated all women in the study. So for those categories, it was statistically significant for both groups. There were also findings that for all women, not for the women, maybe because there weren't enough of the women in that group for with mental health issues, for example, that cannabis was statistically significant for helping women who had mental health issues in terms of improving their orgasm response. So, and it didn't matter. What was not statistically significant was how long they were using the cannabis, meaning some women used it 1 to 3 years, other women used it 5 or more years. So it's not like it took X period of time. That was not statistically significant how long it took to use it. And I did interview, so it was a mixed methods study where I also interviewed 40 women, 20 with and 20 without FOD. And I had women comment to me, and I'll just share one particular story of a woman who was in she was outside the United States, and I had interviewed her, and she had told me that she had never orgasmed from self-masturbation or partnered sex. And the first time that she had used cannabis, she was able to with her partner, because she told her partner, listen, I have this problem. I don't know how to solve it, but I have this problem. And he said, well, try this. And she used the cannabis, and it's no longer an issue. And I think that piece, when a woman can actually overcome a problem that is stigmatized and shamed and no longer carry that around as a burden, there's a dimension of confidence that these women experience, that I could feel the confidence that they had, saying some women said, I use this, my partner uses Viagra. So they were able to, there is a solution for men, but there really isn't one for women. And this can be that solution. So the dosage is something that Dr. Tischler had talked about, because New Mexico tabled it. That was the other state that there was one new commissioner on their board who said, cannabis is not a first-line treatment for FOD. Well, in looking at JAMA in the Journal of American Medical Association, I had sent some follow-up articles. The Journal American, cannabis is not recommended as a first-line treatment for any condition. So it is used when there are very few conventional treatments, and the conventional treatments that exist don't seem to work. So that is, that's what I appreciate you listening. I appreciate you, and I welcome any questions you may have. Thank you. Yes. I'm not sure if I call on you or
yeah.
Tina, or I just.
Yeah, no, I thank you for that presentation. I think Dr. Perlson raised his hand.
Okay.
Yeah, Dr. Mulvihill, thanks. That's helpful. I had a couple of questions.
Sure.
One is cannabis effective for FOD generally when it's used situationally, that is prior to a sexual encounter, or is it used on a more regular basis? And the second question is it effective when it's used only at psychoactive doses or at smaller doses than that?
It's a good question. So I can share with you what from the women that I had talked to, they knew exactly how much they needed to use. Meaning some women said, I take one hit. Some women said, I use a quarter of a brownie that I use. So it is known like to be used in smaller doses to start. Like if we were to approve this, then a doctor was going to say, listen, yes, how do we start? We start with small doses, very small doses, and it'd be recommended that they would start on their own. And the first question was whether they used it before sex or not. So I'm going to use Dr. Becky Lynn's result for that. What she said was women who used cannabis more frequently, whether they used it before sex or not, were twice as likely to report orgasm satisfaction. Whereas it was almost the same result if they used it before sex. It was 2.13 times more likely. So it was whether they use it before sex or they use it more frequently. So what that means is they don't necessarily need to use it more frequently if they only use it before they're having sex.
Okay, gotcha. That's helpful.
Thank you.
Dr. Sounder?
Dr. Mulvihill, thank you for your excellent presentation. A sort of a follow-up question to Dr. Perlson's, which is, were you able to ascertain a dose response? Were you able to ascertain what the dose was for the patients in your study?
Not specifically, other than saying what the research across the board has said low doses. So, I have talked to the woman I had shared the story about. She shared we're using a word joint. Like I was totally against cannabis before I went on this path. I'll just tell you, I was never someone who used anything like this, but I was not able to, we didn't measure it. It wasn't I measured it by asking them questions. And in all the other studies, that's how they measured it. Koff in 1974 found that it was, back then the percentages were only like 1% THC, and he gave a range of what the THC percentage was that was beneficial.
Thank you.
Any other questions from the board?
It's Dr. Prywis. Thank you again, Dr. Mulvihill, and I appreciate the information that you sent me. I have a question, not being an OBGYN or a psychiatrist, just in terms of for the physicians who are not familiar with this condition. Obviously, it's a DSM-5 diagnosis for psychiatrists, but for the average physician out there who's unfamiliar with this condition, would you recommend, in a sense, since you're a therapist and you make this diagnosis, perhaps you may be the first person to encounter the patient who has this, that they then follow up with a gynecologist or psychiatrist who would then refer them to our program for registration? Is that how you would have this work? Because you obviously, as a therapist who's seeing these patients, cannot refer them directly to the program. You would have to refer them to to a physician who would then be familiar with this condition. So I was
That's
just
correct.
curious about how, logistically you see this working within our
Well,
program.
and I think also the fact that typically a woman would go to a sex therapist first, and that it has been recommended to be used as an adjunct to therapy is the way that it would go. So they would go to a doctor. Now, typically, just like the one that was just approved, there isn't going to be doctors that have the experience with recommending dosage on a new condition. So I think that's the spot that we would need to, I could bring Dr. Tischler in or Dr. Becky Lynn when we want to start making a recommendation from doctors that are already recommending. And I don't know if we want to use the word prescribing cannabis. I don't think they use the word prescribing yet because it's not a FDA approved drug. But I think the women who would go either first see their therapist, or they would come in to I mean, when I first went in, I was in Florida and I went to see, I got it because it's only a medical prescription. So I went to see the cannabis doctor and I was able to get a prescription or a medical cannabis card and for the condition. So that's how, and she made recommendations in terms of how to use it. And this was someone who was specialized in really cannabis medicine.
Right. I just want to be clear that, certainly cannabis can help with anxiety. It can certainly help with intimacy and all of those things. But we want to, as medical doctors here on the board, be clear that what it is that we would be approving is for a specific DSM-5 condition and not someone who just wants to use marijuana, for pleasure or for intimacy. So I just want to be able to make that distinction so that physicians who are out there who have patients are doing it for a medical condition.
I think that's appropriate.
Any other questions from the board? Do I hear any motions?
I would like to move approving the petition.
Do I hear
I
a
would
second?
second.
Dr. Perlson? All those
Yes.
in favor, signify by saying aye.
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 Any against? I think there were all four voting for it. Okay, just to clarify for points of the regulations, you do believe that this medical condition is disease is debilitating?
Yes.
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 Okay, and is marijuana more likely than not to have the potential to be beneficial to treat or alleviate the debilitation associated with this medical condition?
Yes.
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 And are there any other matters the board considers relevant to the approval of this petition?
Is this for adults and people under the age of 18 or only for adults?
The petition, let me just look at that
Just
again.
for adults. Just for adults.
Just for
I believe.
adults.
Adults. Yeah.
Adult use.
It's just for adults.
Okay, helpful. Thank you.
All right, so then we do not have to ask the next question about under 18. And so again, with this condition, we will be circulating some paperwork for you to fill out. So that concludes item number 4. And I thank you all for your time. And again, apologize for the difficulties in the beginning of the meeting, but we got there and appreciate everyone's attendance. And we will see you next time, unless, so I take a motion to adjourn.
So moved.
So
Second.
agreed.
All those in favor?
Aye.
All right.
All right, the meeting is adjourned. Thank you all.
Thank you.
Have a nice weekend.
Yes.
Thank you.